Cervical manipulation forces and cervical artery strain. Is damage possible with high velocity, low amplitude adjusting? The issue of manipulation and stroke can be debated on a number of different levels. Most often, though, there is the cause and effect debate related to the context of occurrence. We know, though, that cause and effect can only be determined through a prospective study, and given the rarity of stroke related to vertebral and carotid artery involvement, it's impossible to conduct a study with enough patients to collect meaningful data, even if conducted over decades. The next perspective is where and when. In other words, does it occur more often in a chiropractic office compared to other settings and scenarios, such as a medical office where manipulation is not performed, or even activities of daily living such as turning your head while driving or getting your hair washed at a salon? Well, let's explore this using a quick analogy. If someone died while eating a hamburger at McDonald's, would it be likely that the hamburger was the cause of death? Most people would realize that this would probably be the last possible cause unless the individual choked on the hamburger, and more likely that the individual died due to a spontaneous occurrence of a stroke or heart attack. Or perhaps they walked in with either of these processes in mild symptomatic progress and just happened to be at McDonald's when the terminating event occurred. So it's unlikely that the public would avoid all McDonald's because they kill people, but assume that this is a rare and coincidental occurrence. Some might argue the accumulative effects of a bad diet, but again, there are too many confounding factors of daily living that come into play to come to this direct cause and effect accusation. So clearly, one of the considerations for a cause and effect relationship is, does it seem feasible? Well, certainly the mechanical relationship of the adjustment or manipulation and damage seems feasible, but are we subconsciously biased by having been exposed to the portrayal of, let's say, the movie assassin with chiropractic-like skill in applying a quick, violent rotary execution? In other words, is it that far-fetched to consider that it is in part an unconscious extension of the movie scenario to imagine that chiropractors might inadvertently apply enough force to cause damage, given it's clear that excessive force makes a cracking sound and kills, at least in the movies? So the physical place or scenario can lead to assumptions, including assumptions of feasibility. The cause and effect issue will likely never be determined, given the limitations of study sample size and rare occurrence. But the basic science answer to how much force and strain is imposed on the neck of a patient can at least be simulated and measured. So the question to be answered is there evidence that the degree of mechanical strain from neck manipulation is sufficient to cause damage to cervical arteries either in a single event or over multiple applications? This is where the work of Herzog and his colleagues has focused and where we will focus this presentation. There are multiple publications, many over recent years, including 2012, that attempt to answer the questions regarding the degree of strain or stress imposed on cervical arteries, including the vertebral and internal carotids, and the likelihood that these forces are sufficient enough to cause damage. The research designed to answer these questions can be approached from several angles. What are the forces and strains to these arteries with normal activities? What are they related to range of motion testing, and then what are those related to manipulation? Comparing these might indicate the likelihood that manipulation is more dangerous, putting the patient at more risk than simple living, or the opposite, no added risk beyond normal activities of daily living. The title of this recent publication is Vertebral Artery Strains During High-Speed, Low-Amplitude Cervical Spinal Manipulation by Herzog et al., published in the Journal of Electromyography and Kinesiology in 2012. Let's start with what we do know from the current literature. Peak forces for cervical manipulation is about 200 newtons or 44 pounds. Thrust speed is consistent at about 100 to 200 milliseconds. Forces applied are similar for male versus female clinicians and patients versus non-patients in lab settings. If cadavers are used in the measurement of manipulation forces, it would be important to ask if the forces are the same for live patients compared to cadavers. It might surprise you that it has been consistently shown that forces applied are significantly greater and faster for cadaveric manipulations than for live patients. A quick review of relevant anatomy. As a reminder, there are four divisions or segments of the route for the vertebral arteries. V1 is from the origin off the subclavian to the transverse foramen of C6. V2 is where the vertebral arteries ascend through the transverse foramen of C6 to C2. V3 is where they course upward and laterally to enter the transverse foramen of C1, where they're fixed by fibrous tissue, and then by making a turn around the articular pillar and piercing the atlanto-occipital joint capsule, they reach the dura mater at the foramen magnum. And V4 is the segment from the foramen magnum to the lower border of the pons, where it's joined by its partner to form the basilar artery. The current evidence suggests that damage is unlikely for the distal extracranial loop of the vertebral artery between C1 and the foramen magnum, and the loop between C6 and the vertebral artery's origin from the subclavian artery. Let's look at how the current study was designed. Range of motion was compared to spinal manipulative therapy, or SMT, on a set of cadavers. All range of motion and SMT testing was performed by 3 licensed chiropractors. So how was strain measured? Sonomicrometry crystals were implanted into the walls of the arteries. The crystals served as a receiver and a transmitter of short ultrasound pulses. The time it took for the signal to travel from one crystal as the transmitter to the next partner crystal, the receiver, determined strains indirectly through measurement of stretch while the neck was moved through testing with either range of motion or spinal manipulative therapy. A strain of 5.4% would indicate that the vertebral artery was stretched by 5.4% from its original length at neutral. A strain of negative 3.2% would indicate a shortening of the vertebral artery of 3.2% from neutral. Here we see a comparison of strain forces between range of motion testing and SMT at V1 and V4. We can see an inverse relationship in 2 ways. At V1, strains are about twice that for spinal manipulative therapy versus range of motion, whereas at V4, it's the opposite, with range of motion testing strains at 3 times that of SMT strains. That being said, the largest strain forces were still, at their highest, only 6.2%. This bar graph demonstrates the range of strain forces for each range of motion test and SMT test and vertebral artery division. We can see the highest strain at 12.5% for range of motion testing on the V4 segment. In a second study, we see again comparison of strains for range of motion testing and SMT testing, but at V1, V2, and V3. What is clear is that range of motion testing always produces higher strain forces than SMT by at least 3 times, and that strain increases from V1 to V3. But still, the highest strain, even for range of motion testing, is only about 12%. Another way the researchers looked at the data was as a ratio between SMT and range of motion. This demonstrates that at V1 and V3, the ratio is about 55%, at V2, around 36%, and at V4, 22%, meaning that the strain was always less for SMT than range of motion by anywhere from 1/4 to 1/2. Mean failure strains of vertebral arteries have been reported previously to be, on average, 58%. As a reminder, there is one theory that occlusion causes the symptoms of VBI, but the thrust phase of neck SMTs lasts between 100 to 150 to 200 milliseconds, so that any occlusion would likely have little or no effect on blood flow to the brain. Another theory is that there is microdamage due to repeated strain from multiple manipulations over time. This concern was studied in a recent publication entitled Microstructural Damage in Arterial Tissue Exposed to Repeated Tensile Strains by Austin et al. In the Journal of Manipulative and Physiological Therapeutics in 2010. Using a 6% strain and 30% strain over 1,000 repeat stretch cycles and comparing to a control of 0% strain, results were interesting. There was no damage at 6% strain, but 1,000 cycles of 30% strain caused significant microstructural damage to the arterial tissue. But according to the available literature, SMT strains range from only 0.9% to 6.2%. Now, let's move to another Herzog et al. Study involving the internal carotid arteries. It's entitled Internal Carotid Artery Strains During High-Speed, Low-Amplitude Spinal Manipulations of the Neck, published in the Journal of Manipulative and Physiological Therapeutics in 2012. Similar to the vertebral artery study, ICA strains were measured in cadaveric specimens utilizing 10 different neck adjustments using high-speed and low-amplitude manipulative techniques and with 8 head and neck range of motion tests. Procedures for the cadavers were that all unembalmed human cadavers were utilized 72 hours after death. No ligaments, muscles, or bones were cut to preserve the mechanical behavior of the ICAs. The ICAs were injected with ultrasound gel to obtain a normal shape and also to enhance ultrasound transmission used for the strain measurements. Now, crystals were placed in the lumen of the artery and then sutured to the ICA wall. All testing procedures were repeated 3 times on all levels and on both sides of the neck. This included a sequence of range of motion testing, including flexion, extension, rotation, and lateral bending, a vertebral basilar insufficiency test with rotation and extension. Neck SMTs with the cadaver were performed supine. A diversified lateral rotary manipulation and a lateral manipulation were delivered at all levels of C1, C2, C3, C4, and C6, C7. Then, the ICAs were stretched to failure at a speed of 60% strain per second. There were 1,080 strain measurements during SMTs and 864 during range of motion testing, resulting from 36 clinician ICA combinations. The mean failure strain of the ICA was 59%, plus or minus 16%. Similar to vertebral artery testing, range of motion testing strains were significantly greater than the corresponding maximal strains for the SMTs. The mean of all maximal ICA strains obtained with SMTs was 28% of that measured during the range of motion testing. It was only 10% of the failure strain of the ICA. Again, the internal carotid artery strains are smaller during SMTs than would be expected during normal everyday movements of the head and neck, which include movements such as head flexion that often result in little or no strains of the ICA. There is a factor in these studies that needs to be discussed: slack. In initially slack ICAs, the strain measure did not indicate stretch of the ICA, but corresponded to an unfolding of the slack artery. Therefore, no stress or force was ever applied to the tissue. Damage could never occur in these slack arteries due to longitudinal stress, as stress from stretching the arterial wall never occurred. Another discussion item is how failure strain might have been affected in this study. The older age of the cadavers, the implementation of the sonomicrometry crystals, the dissection procedures, and the removal of the artery would have compromised their integrity. It's important to note these violations of integrity because it's likely that the strain to failure occurs early in this study compared to uncompromised arteries. The researchers note that strain on the ICAs is dependent on points of fixation to other tissues and the relative movement of these points during range of motion and SMT testing. However, because they left these points of attachment intact, they would be similar to live patients, and these points of fixation do not change with death. A limitation may be that the techniques used in this study do not represent all techniques used in chiropractic practice. Techniques discouraged by the profession because of their excessive rotational force or overstretch are not acceptable anyway, so the researchers focused on the most commonly delivered manipulations performed with reasonable range and caution. Yet some older SMT techniques may possibly exceed those strains measured during the range of motion tests by involving movement of the head and neck to the very end of the range of motion. So to summarize what these studies in total can't tell us, they may not represent the actual strains because they are mathematical approximations. However, the procedures used are consistent with strain measurement studies for other tissues. The cadavers are older and so therefore may not represent all vertebral arteries. And of course, some chiropractors and others who perform manipulation may use excessive rotary or stretching forces that were not captured by these studies. However, it must be assumed that the vast majority of practitioners use the types of adjustments simulated in this study and use caution. What we can say is that it is far less likely than casually assumed that the forces of manipulation are damaging, and in fact are likely similar to those of daily movement. Also, repeated movements similar to these simulated adjustments with repeated use in the same patient with reasonable standardized application does not cause damage. Manipulation based on basic science is a relatively safe procedure when compared to other approaches to neck pain and headache.